Lab Medica webinar, STI screening in Zimbabwe, challenges and opportunities from the STICH and IPSAZ studies. My name is Kate and I'll be your moderator for today's presentation. Today's webinar is presented by Lab Medica and sponsored by SEKISUI Diagnostics. Throughout the presentation, please feel free to submit any questions that you may have. You can do so by simply typing your question in at the bottom of the chat tab on the right side of the screen. We will respond to as many of your questions as we can during the question and answers session after the two presentations that we currently have. And with that, I am delighted to introduce our speakers today. Our first speaker is Dr. Kevin Martin. Kevin is a clinical research fellow with the London School of Hygiene and Tropical Medicine, UK, and the Health Research Unit Zimbabwe at the Biomedical Research and Training Institute. He is the principal investigator for the IPSAZ study, which aims to evaluate the implementation of point-of-care testing for STIs within antenatal settings in Harare, Zimbabwe. Our second speaker is Dr. Chido Daziva Chikwari. Chido holds a PhD in infectious and topical diseases from the London School of Hygiene and Tropical Medicine. She holds a joint appointment with the London School of Hygiene and the Tropical Medicine, UK, and the Health Research Unit Zimbabwe at the Biomedical Research and Training Institute. She was the principal investigator for the STICH trial, an evaluation on the STI testing intervention for youth, and the Zimbabwe principal investigator for the GIFT study. So, without further ado, I'm going to welcome Kevin onto the stage.
Hello everyone, thank you very much for joining. My name is Kevin. I'm a clinical research fellow at the London School of Hygiene and Tropical Medicine and with the Health Research Unit Zimbabwe. And myself and Dr. Chido Daziva Chikwari are going to talk through our presentation, Burden of STIs in Zimbabwe, Lessons from the STICH and IPSAZ studies, and Operational Considerations for STI Screening in Zimbabwe. So to give an overview, I'm firstly going to talk through the background to the talk. So that's going to include some background on sexually transmitted infections and their burden and morbidity, a bit about the country context in Zimbabwe, and then about syndromic management, before moving on to the IPSAZ study, which investigated STI screening in antenatal care. And then I'm going to hand over to Chido, who's going to talk through the STICH trial, and then round off with the lessons and opportunities learned from both studies. So in terms of the global STI burden, you may have seen this map or similar before, and really what this is showing is that for the 4 main curable STIs with the highest incidence globally, so that's chlamydia, gonorrhea, trichomoniasis and syphilis, they contribute an estimated 1 million new infections every single day. But what you can see is that these new infections are not distributed evenly across the globe, with some regions having much higher burdens than others. And when we consider this in prevalence terms, what we can see is the WHO African region has the highest estimated prevalence for trichomoniasis, gonorrhea, and syphilis. And this is problematic when we consider the morbidity associated with sexually transmitted infections. So, for example, chlamydia and gonorrhea can cause pelvic inflammatory disease, which itself is associated with infertility, chronic pelvic pain, and an increased risk of ectopic pregnancy. STIs, both ulcerative and non-ulcerative, are also associated with an increased risk of HIV transmission. And these STIs, chlamydia and gonorrhea, are also and trichomoniasis, are also associated with adverse birth outcomes in pregnancy, such as preterm birth and no birth weight. And furthermore, chlamydia and gonorrhea can lead to ophthalmia neonatorum, which is neonatal conjunctivitis, if kind of transmitted vertically during delivery, and also chlamydia can lead to neonatal pneumonia. And then in terms of Zimbabwe, Zimbabwe is a landlocked country in southern Africa, has an estimated population of around 14 million. And I think important, it's a very youthful population. So a third are estimated to be younger than 15 years of age, and a further third are aged between 15 to 29 years of age. And this is an important consideration when we think about both the effect of demographics on STI risk, and then also thinking about STI screening interventions. So this is particularly relevant for the STICH trial, which Chido is going to discuss. And then finally, Zimbabwe has a high prevalence of HIV and has had a generalized HIV epidemic, with prevalence estimated to be around 10.5% by UNAIDS in 2023. Then in terms of syndromic management, syndromic management is a standard of care for managing STIs in Zimbabwe, but kind of also across Southern Africa, many other regions of the Global South. And this is the provision of treatment to cover individuals who present with symptoms and or signs that might be caused by an STI. So this flowchart is the flowchart from the Zimbabwe National Guidelines for the Management of Vaginal Discharge Syndrome. And if we follow it, what you can see is that if someone presents with vaginal discharge syndrome, they at a clinic, and that's assessed and it's present, then they're treated for the things that are likely causing that. So chlamydia, gonorrhea, trichomoniasis, and bacterial vaginosis. And there's some benefits to syndromic management. Firstly, it's relatively cheap. The main consumable costs are just the antibiotics. You also enable kind of rapid treatment for the patient who, after a quick assessment, can kind of be treated and go on their way. And additionally, as you can imagine, this can be implemented kind of at different levels of the healthcare system. So even in remote and rural outposts and primary care and other community settings, this can be implemented quite easily. However, as you can imagine, there are disadvantages to this. So firstly, syndromic management, by definition, can't detect asymptomatic STIs, which the majority are. And so if you rely solely on syndromic management in a population to detect and treat STIs, the majority of STIs will not be treated. Additionally, you conversely have the risk of over-treatment. So as you can imagine in this instance, if someone came in with vaginal discharge that happened to be caused by trichomoniasis, they're also receiving treatment for chlamydia and gonorrhea. And this has impacts in terms of antimicrobial resistance, antimicrobial stewardship. So we're providing treatment for infections that aren't necessarily there. And this is important both for STIs, but actually thinking more broadly about other bacteria and other infections. Additionally, when we're providing kind of unnecessary treatment, there's also costs and potentially side effects associated with that. And as a result of the limitations associated with syndromic management, there's been an increasing push in recent years to think about if diagnostics can be used instead. And so this diagram is a few years old now, but really what it demonstrates is that there are diagnostics available, but currently kind of more in the pipeline that can be used to diagnose individuals with STIs. And there in particular has been this focus on diagnostics that can be used at the point of care. And that's because if we provide a diagnosis at the point of care, we can also treat them and hopefully reduce loss to follow-up. And in both IPSAZ and STICH studies, both the awesome trichomonas rapid test and the gene expert for chlamydia gonorrhea were those that were used for chlamydia gonorrhea and trichomoniasis. And so that then brings me on to the IPSAZ study, which stood for Investigating Point-of-Care Diagnostics for Sexually Transmitted Infections and Antimicrobial Resistance in Antenatal Care in Zimbabwe. And the aim of the IPSAZ study was to implement and evaluate a strategy for integration of point-of-care diagnostics for sexually transmitted infections into antenatal care settings in Harare, Zimbabwe. And the rationale for choosing antenatal care was that, first of all, there's existing HIV and syphilis screening already embedded within antenatal care. So there's already a platform on which we could have added additional tests in. Antenatal care is also a key point of access for women with the healthcare system. And so in terms of accessibility, it's a good point to try and access those women. Pregnant women themselves are also a risk population for STIs, and so yield of screening might be higher than compared to, say, the general population. And then also, as mentioned, chlamydia, gonorrhea, trichomoniasis, and syphilis, of course, are all associated with adverse pregnancy outcomes. And so actually by screening and treatment for these STIs in pregnancy, there's at least the potential for the aversion of these adverse pregnancy outcomes. And so to answer this aim, we conducted a prospective interventional study and enrolled pregnant women who are attending for antenatal care within 2 primary healthcare centres in Harare with a target sample size of 1,000. And then in terms of the study procedures, following written informed consent, we had 2 provider-collected vaginal swabs and 1 finger prick blood sample collected, which were then tested for chlamydia and gonorrhea using the gene expert platform, for trichomoniasis using the awesome trichomonas rapid test, and for HIV, syphilis, and hepatitis B using rapid diagnostic tests. At this point, the rate limiting factor really was the gene expert, which had a processing time of 90 minutes. And so in this time, we collected data on other socio-demographic factors, sexual behavior, and other STI risk factors. And participants kind of went and did their other routine antenatal care activities, and then they returned for their results. If negative, we just provide health promotion advice and counselling. And then if positive, we treated or referred on as per guidelines. And specifically, if hepatitis B positive, we took blood samples for hepatitis B viral load and ALT testing and referred on to secondary care to see a specialist, and provided birth dose vaccination for their newborns. And then alongside this, we also conducted qualitative work as part of a mixed methods process evaluation as per the MRC process evaluation framework. And so the qualitative component included in-depth interviews with pregnant women, with partners, with HIV testing counsellors, midwives, the intervention team, nurses in charge at the 2 clinics and a specialist physician, and focus group discussions with pregnant women. And alongside this, we collected additional observational data like unstructured observations, time and motion, and collected a context diary, and really put this together with the routine monitoring data like uptake of testing, treatment, and partner services for the process evaluation. And then the qualitative data was analysed thematically with open coding and an inductive approach. So moving on to the results, so between January and October 2023, on the study days when our team was at the clinics, 13,500 pregnant women attended, of whom 1,105, so over 8%, were approached for the study. And of those, over 90% were enrolled. So only 2 were deemed not eligible, and other reasons for people not taking up the study included being worried about time and kind of that they might miss their other antenatal activity appointment activities, that they didn't trust testing, that they didn't feel at risk, and conversely that those who were actually worried about getting positive results. And then of those, just 1 was then excluded from further analyses that didn't have a full set of results available. But I think really one of the main points from this slide is that implementation of this strategy was very acceptable, and so had led to a very high uptake of over 90% of those who we were able to approach. And then in terms of those we enrolled, so 70% were from site A, and this was just due to we were spent longer at that particular clinic than the other site, so the rate of recruitment was the same at both sites, which was 5 participants per day. In terms of the age breakdown, so 1 in 3 were aged 20 to 24, 1 in 4 were aged 25 to 29, and almost 30% were aged 30 or above. And the majority, so over 90%, were married or living together with the father of the pregnancy. And then in terms of pregnancy planning, over 40% either would have preferred to put off pregnancy for a while or actually did not want to become pregnant. And so just as an aside, this demonstrates at least like a moderate level of contraceptive need in this population. And this was the first pregnancy for almost 1 in 3 participants. And the majority of participants were attending their booking visit, so 72%. Then in terms of STI prevalence, so HIV prevalence was 10.5%, and of those 105 diagnoses, 20 were new, so the other 85 already knew they were living with HIV. Chlamydia prevalence was 18.5%, trichomoniasis was 12.4%, gonorrhea was 4%, 3.5% tested positive for syphilis, 1.4% were diagnosed with hepatitis B, and that meant that 31.5% were prevalence of at least 1 non-HIV infection, and 30.7% had a curable STI. And I think really importantly is that, as you can see on the right-hand table, the vast majority of this population were asymptomatic. And so only 56 reported had any symptoms of vaginal discharge, pelvic pain, or dyspareunia. And I think the main take-home point here is that if you relied solely on syndromic management, the vast majority of these infections would not have been detected. And then briefly, just to mention STI prevalence by HIV status, is just to say that those individuals living with HIV, they had a higher prevalence of each STI individually and also combined. And then just considering the treatment cascade for those participants who were diagnosed with a curable STI. So of those who were 308 who were positive for at least 1 of chlamydia, gonorrhea, trichomoniasis, or syphilis, 303 were treated on the same day. 5 were treated after the day of testing, and so that meant that none were untreated. And of those who were negative, again, similarly, the vast majority, 98.6, collected the results on the same day. 1% returned after that day for the results, and only 3 actually didn't return for the results. And again, just want to highlight that really, that overall this showed that for those participants we enrolled, we were able to provide kind of same-day testing and treatment service with almost all of those with a curable STI treated on the same day. And then in terms of partner notification, so of those with a curable STI, over 90% took up at least one partner slip, but only 1 in 3 had a partner attend for treatment. So now I just want to talk through some of the process evaluation findings and talk through a bit about the cascade of people attending and then the screening process and some of the facilitators and barriers to that. So if we consider what happens then when a participant attends for antenatal care, they are then offered testing, they then agree to testing, and they're tested. And they will then either wait or return for the results, and if positive, would then accept treatment. But really, there's barriers at each stage of this process. So first of all, there's barriers to access. So for individuals to even attend antenatal care in the first place, there are antenatal booking fees. So at both clinics that we were based at, that was $25 US, which is quite a substantial amount. And some individuals were exempted, they had access to a voucher system, but for many others, they kind of had to raise those funds themselves. Additionally, many had additional transport costs to actually get to the clinic, which acted as a barrier for them to access antenatal care. Then there was barriers to kind of agreeing to testing. This included worries about time, but also stigma around screening and being worried about being seen to be getting up and kind of going into the screening room. And then also there was concerns about follow-up. So in our study, we were by being able to provide testing and treatment on the same day for the vast majority of individuals, this was less of an issue. But what was reported by the HIV testing counsellors who also did syphilis screening was that they often had challenges following up individuals for syphilis treatment if they weren't treated on the same day, particularly at one clinic that had a very large catchment area. And this all contributed to coverage of the intervention. Then thinking about what our aim was, and that was really to do same-day testing and treatment. And one thing that affected this was a heavy reliance on technology. So one thing that influenced throughput was that we used a 4-module gene expert machine, so limited really how many tests could be processed each day. Additionally, there was the challenges of if there was any technological difficulties, this had the potential at least to really severely derail testing. And then another factor was that our team mentioned there were lots of challenges using lots of different tests and platforms. So they had to collect multiple different samples and then test them using different tests, each with different processing times, which they had to measure with different timers. And this was just keeping track of all this within quite a busy clinic environment was very difficult. Then thinking about acceptability, as from the uptake, you can see that overall this was a very acceptable intervention, and really the interviews and the focus group discussions really reflected that. Lots of people saying they really valued this additional screening. And there were a few important things to mention that did also influence this. One was time for results. There were a few complaints about how long it took time for results to be produced, but generally this wasn't actually an issue, as most people did receive their results before their other antenatal processes were being completed, so didn't have to stay longer at the end of the day for their results. A quite important factor when we think about the future and how we implement this and scale it and so on is that screening was provided free of charge in our study, but actually many participants reported that they would not have been able to kind of fund this themselves, and they're already subject to lots of out-of-pocket expenditures. And then also workload. So we kind of really, for feasibility issues, we had to restrict recruitment to 5 individuals per day at each clinic. But even with that, the team reported that there was quite a high workload to be able to complete everything. And that's even if you took out kind of the research specific processes, there are limitations to kind of throughput and the level of workload associated with that. And then just thinking about integration, and that was with the routine antenatal care services. As I mentioned, the research processes probably did influence that in terms of consent forms and questionnaires. But actually, other than that, the team did say that generally they did seem to integrate quite well with clinic staff, although there were some challenges which I'll come on to shortly. And that was really one thing that's really important, is that this was ultimately affected, implementation was ultimately affected by the overall context. And this is at the clinic, health system, socioeconomic and cultural levels. So implementation took place within a very overburdened healthcare system, and this included things like chronic staffing issues and a reliance on locum staff. And this then led to some challenges with integration. So the team often reported that they would develop a really good rapport with the usual team, but then one day there'll be a lot of locum staff who they'd then have to re-explain what the screening was, and this was difficult to kind of have to do, and it did lead to some disruption. And then also another really big socioeconomic factor is just that participants are already subject to out-of-pocket expenditure, and often reported that they would not have been able to contribute more. And so just to briefly summarize some of the findings from the IPSAZ study, first of all, we found a very high prevalence of sexually transmitted infections among this largely asymptomatic group of pregnant women who were attending for routine antenatal care. We found a high level of screening uptake and acceptability and the ability to deliver same-day treatment for those we enrolled. However, one important factor was that the two clinics we were at were very high volume clinics, and so as a result, when we considered all those who attended for antenatal care, actually we had quite relatively low screening coverage, and we weren't able to kind of approach the vast majority of those individuals who were attending. And so some implementation challenges related to this was the testing capacity, kind of with the Gene Expert machine, also the difficulties using multiple different test platforms, and also the high workload of kind of even only enrolling 5 per day at a clinic. The intervention team found this very challenging. And then there was importantly the contextual challenges. So implementing this in a very overburdened healthcare system, the chronic staffing issues affecting integration with routine care, and thinking about how such programs and screening would be funded in the future already were reliant on out-of-pocket expenditure for routine antenatal care in Zimbabwe. So just that's the summary for the IPSAZ study. I'm now going to hand over to Chido, who is going to talk us through the STICH study. Thank you very much.
Thank you very much to Kevin. So as already introduced and mentioned by Kevin, I will be presenting the STICH study. And STICH is actually an acronym for STIs in Chiedza. And nested within a larger trial that I'll talk briefly about was a smaller trial to investigate the impact of providing STI testing and comprehensive STI management integrated within this larger intervention on the population prevalence of STIs among youth. So it's a slight pivot from Kevin's study, which was within a healthcare facility setting, but rather within a community setting and offered to young people only. The larger trial, which is Chiedza, offered a comprehensive package of HIV and sexual and reproductive health services, including HIV treatment and monitoring, HIV adherence support, a component of sexual and reproductive health services, including pregnancy tests, contraception, condoms, referral to voluntary medical male circumcision, menstrual health products, and also general health information and counseling. So as part of this intervention in the community for young people, we embedded a trial of STI testing. And the trial had 2 components. The main component was the intervention, and the intervention was delivered over 12 months in 8 communities in Harare and Bulawayo, which are the largest cities in Zimbabwe. And young people aged 16 to 24 who lived in these 8 communities were able to access STI screening at a Chiedza site for 1 day a week within that community. We offered testing for chlamydia and gonorrhea, and we did this at a laboratory close to each site on a Gene Expert platform. And so young people who came to the Chiedza site would leave a urine sample if they wanted screening for STIs. And this urine sample was then taken to a local laboratory and tested, and they could access their results within a week by coming back to the Chiedza site. And we also followed up young people who tested positive for either chlamydia or gonorrhea over 3 months via telephone. We also offered testing for Trichomoniasis vaginalis and this was offered only to females, and we used a lateral flow test, the OSAM test, and young women could self-collect vaginal swabs at the Chiedza site, which is in the community. The swab was then tested using the OSAM lateral flow test, and the results would be available within 15 minutes, and young women who tested positive for TB could access treatment on the same day. As mentioned by Kevin, the national guidelines for Zimbabwe follow a syndromic protocol, and so any young person who came to the site could access testing, but could also be treated via syndromic management. So after offering this intervention for 12 months in each community, we then went on to do a population-based prevalence survey of STIs. The survey was conducted over 3 months in the 8 intervention clusters and an additional 8 control clusters. And here we screened young people aged 18 to 24 years for the 3 STIs using a multiplex platform. The reason why we used a multiplex platform was because of the high volumes of young people that we were testing each day in the prevalence survey. For all young people tested in both the intervention and the outcome survey, we offered partner notification slips for those who tested positive, and their partners could come back to the site for treatment free of charge. All the services offered in Chiedza were also free. And so here are some of the headline findings from the intervention. We had very high uptake of screening for chlamydia and gonorrhea, with over 86% of eligible young people having had at least one test. Our uptake of screening increased with increase in age. So the 16 to 18-year-old age group, about 78.9% of young people took up a test. But in the 20 to 27-year-old age group, 91.6% of young people took up a test. Among males, this was 87.5%, and quite similar also among females at 86%. I would like to highlight, when we stratified by HIV status, we found that young people with an unknown HIV status were less likely to be tested for an STI. And so among young people living with HIV, testing uptake was 92.9%, but among young people with an unknown HIV status, STI testing uptake for chlamydia and gonorrhea was only 43%. When we look at TB screening uptake, and this is where among young women only, they self-collected a vaginal swab and the TB testing was done on site. Uptake was 85.2%. It also increased with an increase in age, and we saw the same trend among young people living with HIV and those with an unknown HIV status. The prevalence of STIs was quite varied. So the prevalence of chlamydia overall was 14.7%. The prevalence of gonorrhea was 2.8%. And the prevalence of TB among females was 7%. When we look at the prevalence of either chlamydia or gonorrhea, this was 19% among females and 16.3% overall. Treatment uptake was varied. So treatment uptake for chlamydia and gonorrhea, where young people had to wait a week to get their results, the treatment uptake was 60.5%. The treatment uptake for TB was significantly higher, and this is among females where a point of care lateral flow test was available. The uptake of TB treatment was almost universal at 98.3%. When we look at syndromic management, this slide basically summarizes how many STI cases are missed by a syndromic approach, and I'll talk about this a bit later in the following slide. Partner treatment, as I mentioned, was offered to all young people with a positive test for either chlamydia, gonorrhea, or TB. And what you find that among the 1,807 young people who tested positive for an STI, only 5.7% had a partner come back for treatment at our sites. And so to highlight sort of the key findings from the intervention, we had high uptake of STI testing among youth attending this community-based service. we had a high yield of STIs, with majority of them being asymptomatic following testing. We found that syndromic management was not sensitive and identified only 5% of young people with these 3 curable STIs. And there was almost 100% treatment uptake with a point of care test, but this was much lower when clients were required to come back for their results. And overall, we had very low uptake of partner notification. So as I mentioned, we went on to do a population-based survey to assess the impact of this comprehensive screening and management intervention. And I'll now talk through the trial results. Our primary outcome for the trial was the proportion of participants with the positive test results for any of the 3 STIs. Our secondary outcomes were the proportion of participants with a positive result for each of the 3 STIs. And we also had exploratory outcomes for the proportion of participants with the positive test results for either chlamydia or gonorrhea. Overall, our trial had no impact or difference on the primary outcome in the control and the intervention arm. So what you see here is that the prevalence of either chlamydia, gonorrhea, or TB in the STICH communities was 19.1%, and in the control communities, this was 20%. And so there wasn't a difference in the control versus the intervention clusters. When we look at our secondary outcomes, however, we observed that there was a difference in the prevalence of gonorrhea between intervention and control clusters. In the intervention clusters, the prevalence was 1.7%, and in the control clusters, it was 2.9%, so a much higher prevalence of gonorrhea in the control clusters, and this was statistically significant. When we look at the incidence of STIs within the intervention, and I want to highlight this slide because we really believe it explains why we didn't see a difference or an impact in the primary outcome. And what you can see is that the incidence of chlamydia is very high, and it's about 21.5 per 100 person years in the intervention population. Whereas when you compare it to the incidence of gonorrhea, this is only 8.4 per 100 person years in the intervention participants. And so to summarize our trial findings, there was a high prevalence of STIs among youth at population level in Zimbabwe. Our prevalence saw that 1 in 5 young people had either chlamydia, gonorrhea, or trichomoniasis. We found in the intervention that there's high uptake of STI testing among youth in community settings, so they do want to get tested. And we also found that our trial did have an impact on the population prevalence of gonorrhea. We observed a 43% lower prevalence of gonorrhea in intervention clusters. And we believe the reason why we didn't see an impact on chlamydia prevalence is likely due to the high rates of infection of chlamydia and therefore reinfection of chlamydia in the community. And another key finding was that we did observe challenges with partner notification among young people, which left us to ask the question, is the standard partner notification that's available in our context fit for purpose with young people? And so finally, I'll now move forward. So as mentioned by Kevin, we do use a syndromic approach, and it's only within these research contexts that we've been able to offer diagnostic testing for STIs. And so what are the operational considerations for moving towards an approach where we do screen for STIs? I used this slide here to just remind us of some of the process evaluation findings from Kevin's study, which are quite relevant to STICH as well. So there's a high prevalence of STIs, there's high uptake of screening, and depending on the setting, the delivery of results on the same day is varied. When you have implementation, either in community or facility settings, you need to also consider testing capacity and the use of different test platforms as well as the workload on staff who will have to do the screening. There's also contextual challenges that are unique to Zimbabwe, but also potentially to other low and middle income settings, including an overburdened healthcare system, chronic staffing issues that affect integration, and the out-of-pocket expenditure that individuals would face. So when you think about bringing to scale screening for STIs, these are some of the key things that I thought we would want to highlight. The first is that you need to consider demand. In both these studies, we've identified very high uptake of testing. The second is that the Gene Expert platform, which is one of the key platforms that was used in both studies and is widely available in our context, it does have challenges in the sense that it's not necessarily a point of care test, especially if you're looking to use it in community settings. It requires you to wait or return for results. And if you are to wait in an antenatal care setting as presented by Kevin, pregnant women were willing and able to wait. But in a community setting such as Chiedza, where we had high volumes of young people attending every day, they were not able to wait for the results. Using this platform does require considerable maintenance, and as mentioned previously, there is an associated staff burden. In contrast, the point of care test that we used for TB screening was quick and easy to use and also resulted in high treatment uptake. There's always the consideration for costs, and we do have a cost evaluation pending for STICH. And then there's need to think about how would we fund these programs if we are to go forward with them, and thinking about how to better do partner notification. So some of the questions that I'd like to pose to the room, or that we are thinking as researchers in this context, is should we screen everybody for asymptomatic STIs? And as part of that, we need to consider how we are to do this. And these implementation studies have shown some evidence for how we could potentially do that. But we also need to think about the associated cost if it is being done programmatically. We also need to think about the anticipated outcomes. So what are the long-term benefits of screening? As Kevin mentioned, in pregnant women, there's potential impact on pregnancy outcomes and the baby in question. But when we're looking at adolescents and young people, are we looking at more long-term impacts of screening that I think the etiology is not well understood? Which STIs should we screen for? We focused in our studies on chlamydia, trichomoniasis, and gonorrhea, with also HIV and syphilis, but is there a need to prioritize or deprioritize? And then there's also a need to think about overtreatment and antimicrobial resistance when we do offer wide-scale screening for STIs. Similar to HIV programming in these settings, there might be a need to focus on key populations, so young people, as was done in STICH, sex workers, pregnant women, and potentially people living with STIs. There's additional questions about how we can improve partner services for STIs, and also just thinking about what can we learn from successful HIV programs also in this setting. And finally, I will talk about some opportunities. As I mentioned, we have had successful programs, and part of our thinking at the moment is working around how we can integrate STI testing into other existing services so that it does become part of our programming. So the first is that how can we nest it into existing services for high-risk groups? So we're thinking about antenatal care settings such as IPSAZ and a trial that we're about to start in Zimbabwe called PROMISE. We're also thinking about nesting STI screening as part of HIV services, and this is because of the comparable risk and associations between HIV and STIs. STI screening can also be nested within family planning services, sex worker programs, as I mentioned, within mining and border towns where there is heightened risk for youth, and also as part of programming for LGBTQI+ populations. We're really excited about moving forward in sort of implementation modalities, an example of this is the self-sampling for STI. So thinking more about when we do have these amazing diagnostics, what self-care approaches can we use to reach more people with STI screening? And highlighted here is a publication that came out of STICH, where young people within CHIEDSA highlighted that they found the self-swabbing for STI screening highly acceptable and feasible in a community setting. And so there is sort of evidence there about potentially moving to more self-care approaches as well, thinking in mind the burden that is already existing in healthcare settings here. I'd like to acknowledge our really massive group here in Zimbabwe and at the London School of Hygiene and Tropical Medicine for all their support, as well as our funders who have contributed and made this work feasible. And that also includes our young people and staff on the CHIEDSA and IPSAZ studies. And thank you very much for your time this afternoon.
Thank you very much for your time, Shido. That was absolutely incredible. And thank you also to Kevin for your informative presentations there. So before we start the live Q&A session portion of the webinar, I'd like to just remind our audience, feel free to continue to ask questions by just typing in your question at the bottom chat tab on the right side of the screen. So if you don't mind, Shido, we're going to dive right in. We've got quite a few questions here already. Okay, so the first question has two parts to it. So the first question is, what are the key considerations for a good STI test? And then the second part, how do the tests used in your study compare?
All right, thank you so much. It's a really good question. And I will sort of divert to WHO criteria.
Mm-hmm.
They've done a lot of work to understand sort of what are the key considerations for a good STI test. And they have what they term the assured criteria. And that includes sort of tests that are affordable. So cost is really important. Tests that are sensitive and specific. Tests that are user-friendly, rapid, robust, equipment-free, and deliverable to end users. And I think when we look at the tests that we used on the STICH and IPSAZ studies, they are highly sensitive and specific. When it comes to the point of care test that we use for TB, this is the awesome test. We found that, you know, it was user-friendly, it was rapid, and allowed results within 15 minutes, and it was also equipment-free. And I think with the Gene Expert, there are a lot of pros. It is the test that we have available. It is highly sensitive and highly specific, but the cost is quite high and not accessible to the individual person. So as mentioned by Kevin, end users felt that the cost burden is not something that they could bear. It does have equipment that is typically operated by laboratory personnel. And in a context like Zimbabwe, where we don't have a lot of laboratory capacity to test at scale, this then makes it a bit difficult to scale with that platform.
That's great. Thank you so much. And I'm just going through more questions here. This will be a good follow-up question from the answer you just gave. Is rapid testing enough for diagnosis, or does it need a confirmatory test like PCR?
I think when we have tests that are highly specific and sensitive, there isn't a need for us to do further confirmatory testing on PCR. We're at present using a syndromic approach, which means we're actually going in blindly and treating anyway. So if we do manage to get a test that's highly sensitive and specific in a context where PCR is expensive and hard to access for majority of people, I would say that there isn't a need to then go on and do further PCR testing.
Okay, thank you very much. And what would you say are some of the barriers and facilities to bring STI testing to scale in Zimbabwe and in similar settings?
I think one of the key barriers is costs. At present, STI screening is quite expensive. The tests are really expensive. When we present our results to the Ministry of Health, their feedback is that, you know, how can we afford this? What are the potential costing structures? And I think that's a key barrier. When we look at facilitators, I think what we now have is a lot of evidence on the burden of STIs. And I think this makes a really strong case for advocacy. And the ongoing research and the research that's being done has sort of started turning the wheel to bring people's attention to STIs and the burden of STIs, and potentially that is something that could help move us forward.
Yeah, incredible. Thank you. And another question here: how prevalent is trichomoniasis? Trichomoniasis, I cannot say that word today, in Zimbabwe compared to other sexually transmitted infections?
So what you can see in the STICH and the IPSAZ studies is that the prevalence of TB was quite high among women. So it was about 7% in young women who attended the Chiedza trial. And when we look at young people in the community setting, it was also about around 7%, so quite high. But it is lower than chlamydia. So the prevalence of chlamydia in the community was 13%. And then, you know, the prevalence of gonorrhea is quite low, so about 1.7%. And so I would say the prevalence of TB is quite high. It's not the highest. It's not the STI with the highest prevalence, but it is quite high in our context. And also when we're looking at pregnant women, as in Kevin's study, it was 12.4%. So much higher in pregnant women than compared to general population of young people.
Okay. And this follows on quite nicely as well. This last question, I believe, at the moment: how can community education and awareness in Zimbabwe be enhanced to prevent the spread of trichomoniasis, which is the word for some reason I cannot say today? But you know what I mean. You're the professional.
I always just say TV.
TV. I'll be using that going forward. Thank you.
I think so. The question is, how can community awareness be achieved?
So how can community education and awareness in Zimbabwe be enhanced to prevent the spread of TB?
All right. I think as scientists or researchers or programmers or healthcare workers, we tend to talk amongst ourselves. And I think part of enhancing awareness is to let people know, you know, that there is these STIs that exist. These STIs are asymptomatic, so you're not going to present with symptoms. This is how you can prevent them. This is how you can access diagnostics and treatment. And I think I'm a researcher, but I do talk about advocacy a lot. We need to make a lot more noise about STIs. We've focused a long time on HIV, but forgotten all the other STIs. And I think communities can be made aware through campaigns, through knowledge, you know, and information sharing all over. And I think these research studies do provide that information. So prior to STICH, as an example, we didn't know the burden of asymptomatic STIs among young people. And now that we have this evidence, we can use it for advocacy as well.
Incredible. Thank you. And I've got two more questions, actually. They're all coming in now. Which of the STIs had the highest prevalence among those who represented as asymptomatically?
So I think it was gonorrhea. So among people who were screened and also treated syndromically, only 12.5% of those with gonorrhea, symptomatic gonorrhea, were also tested. So gonorrhea does present symptomatically more than the other three STIs.
Yeah. And the final question, can any of these approaches be taken to, how can you increase partner notification? Because you mentioned that earlier. How can you increase partner notification uptake in the future?
That's a really good question. I spend a lot of time thinking about it. I actually have a PhD student who's looking at sort of developing or crowdsourcing new partner notification strategies
Yeah.
for young people. In Kevin's study, one of the things that they've looked at is offering incentives to partners. And
Okay.
I think his paper is going to be published soon. But what we found in that trial was that incentives didn't make a difference. There's also thinking in some contexts about expedited partner therapy, where you give the index, so the woman who's been tested in ANC, you actually give them the treatment for the partner and they take it home. And then there's also thinking about provider facilitated therapy. So the young people in Chiedza told us, I'm scared to tell my partner that I have an STI and that they should get therapy. And so an alternative might be that the nurse or the community healthcare worker be the one that approaches the partner and offers them treatment instead. So there's some thinking, but I think it's a big black box.
Yeah.
And a lot more work needs to be done in that domain.
Yeah, thank you so much. That was incredible. Great answers there. And they all flowed nicely from one to the other. So unfortunately, this concludes our session today. Thank you so much, Tito. And thank you also to Kevin for your wonderful presentations. We'd also like to thank our audience today for joining us and sending in their incredible questions. If we didn't get round to answering any of your questions today, don't worry, we can send you an update on your questions at a later date. So we're going to email the speakers after the webinar and we'll get those answers back to you as soon as possible. This webcast will be available on demand, so on-demand viewing in the next few days. Lab Medica will send you an email notification when the replay is available to view. And we encourage you to share the on-demand webinar with your colleagues who may have missed today's event. Thank you everyone for joining, and until next time, enjoy the rest of your day. Thank you.